Well, I think the most surprising thing is the depth of the support of this community for this medical school. You know, I've been in 5 other medical schools in my professional career, and, you know, there's always a certain amount of town gown tension that takes place. I've never been to a place that was more supportive than this community is supportive of this medical school. And I can tell you that they really proved it. Probably the low point in my professional career was I came out here actually thinking that the funding had already been arranged, by the way. And on June 28th of 2011, in the middle of our getting accredited, the governor dropped us out of the state of California budget. I don't believe there were more than 5 people that thought we could survive such a devastating event, and I think most people expected us to pack our bags and leave town. I went to our community, it's the only way I could think of doing it, and said, listen, I need your help to get this school open, even if we don't have new state support. This is not a wealthy community. You know, this is a hard place to raise money. In 9 months, we raised $100 million, $10 million a year for 10 years from basically this community. And based on that, we went back, got accredited, and we're now taking our first class in medical school. That is an amazing story. I wouldn't have believed it before I came here. It's hard to believe it now. The people of inland Southern California want and need this particular medical school so much they basically refuse to let it die. I think that's one of the greatest stories in American medicine.
Thank you very much. That was good. You liked it, Bobby? Mm-hmm.
So that wasn't for real anyway?
No, but it's good because it's exactly
right. And those are the unique aspects. I think it was a combination of my past experience of being in large academic medical centers in the U.S. and knowing what worked and didn't work. But I think also the international perspective was particularly helpful. And, you know, there are some similarities that we don't like to talk about. For instance, you know, the Flying Doctors, which is a group of Americans that go to third world countries to deliver health care, actually only go to one place in the United States, and that's the eastern Coachella Valley. So there are some lessons to be learned from what works successfully in far more disadvantaged environments.
And that's sort of what I like to talk about is how is the medical school being imagined to realize those goals, both as a structure, but also in terms of choosing the people who get into the school?
Sure. Well, you know, there really isn't any way to do this by just building a med school. So let's go over what our unique missions are. Probably the mission that is most publicized is to specifically address the healthcare manpower shortage in inland Southern California. So how do you get doctors to practice in inland Southern California? The second issue is it's not just more doctors. You need more doctors that are going into specific specialties. So how do you create an environment where a higher percentage of your graduates go into the fields of medicine that are actually needed by society rather than the ones that pay the most or the ones that the students think have the best lifestyle, et cetera. Then we have the interesting challenge of how do we create healthcare professionals, in our case medical students, that are more reflective of the populations they serve. And there are some advantages to doing that, which I'll point out, but it's also the right thing to do. And then finally, the really unique mission of the med school is to actually improve the health of the community we serve. Now, you would think that that would be the mission of every med school in the United States, certainly every public medical school, but it's quite a unique mission in the United States because we tend to not think of populations. We tend to think of the patients that come to our hospital, the patients that come to our clinic. No one tends to, in the United States, to think of the health of our entire population, and we need to move in that direction as we move toward more universal coverage. So, how do we accomplish the first mission, which is we have an overall shortage of doctors in inland Southern California. It's about 3,000 physicians today. It'll be about 5,000 physicians in 10 years. That's a huge physician shortage. We are short of virtually every type of doctor except plastic surgeons. So how do we just get more doctors to practice in inland Southern California? There are only 2 determinants of why doctors practice in any location. Where they come from, equally divided between where they're born, where they went to high school, and where they went to college, and where they finish their training. That is, where they finish their residency training after medical school. So the med school is somewhat irrelevant, if you will. So if I just build a med school, I would fail in that mission. So to be successful in that mission, we, in contrast to most medical schools, have to be very active in pipeline programs to bring more qualified students to be selected in medical school. And this is quite a challenge because inland Southern California has the lowest college going rate, it has the lowest standardized test scores, it has the highest high school dropout rate, and we have to address that issue in part in order for me to have enough qualified candidates to select. So we are actively involved in K through 12. We have success programs not only in our own university, but we're building success programs in other universities with high numbers of inland Southern California students in them. So that's the front end of the med school. Then on the back end, I have to build new graduate medical education programs in the disciplines in shortest supply. Now, I should point out that we are the only new medical school in the United States that is also building graduate medical education programs. Every one of the others, 15 out of 16, are just building a med school on the front end of existing graduate medical education programs. There's probably a greater shortage of graduate medical education programs in the United States than medical schools, so that's very important. So what are those short supply specialties? The three primary care specialties of family medicine, primary care internal medicine, primary care pediatrics, general surgery, OB, and psychiatry. Just a brief comment on the last three. General surgery, because we're largely a rural county, and every one of those small rural hospitals have to have a team of general surgeons in order to stay open, and there's a shortage of general surgeons, and they're critical to maintaining those small hospitals. OBGYN, because we have the highest fertility rate of any area of California, so we have an awful lot of children being born. We need specialists in that area. And psychiatrists, because we tend to not comment on the woeful manpower shortage in mental health services, but it's just as big as primary care, and so we need more psychiatrists as well. Now, how do you do that? Well, the first thing to do is to look for the characteristics in your medical students that will track with careers in those areas. Now, we are fortunate, I guess I would say fortunate, in California in that we have so few medical schools, so few medical school slots, that we have about 10 qualified candidates in California for every med school slot in the state. That compares with a national average of about 2.5 to 3 to 1. So we're woefully under med schooled. But the good news about that is that there's a ton of highly qualified candidates to pick from. I would just argue we're picking on the wrong criteria. Now, granted, you have to have a certain grade point and certain standardized test scores in order to make sure that you'll succeed in med school, but that's still a huge pool. So within that pool, I don't pick the students based on who has the absolute highest grade point or the absolute highest standardized test score. Instead, I look for qualities that help predict going into many of these helping fields. So, for instance, one of the strongest predictors of going into primary care is previous service in the Peace Corps. Think about that. A student that takes 2 years out of their life to do something for other people, potentially in a third world country, probably tells you something about that student that probably tracks with their likelihood of going into underserved areas in our own neighborhood and serving that population. So we put a lot of emphasis on service-based learning, on previous experiences that demonstrate to us an altruism and commitment on the part of those students.
So it would be things like Teacher Corps, Peace Corps.
Sure.
Crafton Community College has an excellent fire and EMT program.
Mm-hmm.
Are those the kinds of things too? I mean, how broad are you going with this sort of more than the test look at?
Well, I think we go quite broad because that's only one aspect. In addition, our interviews are different. We don't just have you show up and take 2 random interviews with 2 faculty members. We use what's called the multi-mini interview technique. And so we have questions generated specifically from our unique missions. And we ask every student, basically, they walk up to a room, they're given a question, they get 2 minutes to think about it, and they walk in the room and they get 8 minutes to answer that question. And that faculty member that hears their answer, hears the answer from virtually all the students that are applying. And it's like speed dating. But what it does is it tells us more things about each of those candidates than a standard interview would. And it's particularly tells us about things about that candidate related to our missions. We also, interestingly, have a different attitude about our partners. You know, we're a community-based medical school, which means that we do not build a university hospital. We partner with all the existing healthcare infrastructure of our own community, clinics, hospitals, doctors, etc. But other medical schools haven't considered their value in selecting students from our own geographic region. So, for instance, a local hospital might have 100 students that volunteer in that, trying to improve their odds of getting to med school. Has anybody ever thought of asking the hospital, and particularly the nurses in those hospitals, out of that 100 students, who are the 2 or 3 that would really make great doctors? They know, you see, because they've worked with them. That knowledge would be very helpful to us in selecting the students that have, if you will, the right stuff. So we put a lot of emphasis on picking students that we think have the right stuff, not only to go into fields that we want them to go into, but have the right personal qualities that you and I would both want in our doctor.
You mentioned Coachella. And that it's the only place in the United States, which brings up serving immigrant populations. Is there in this new medical school model a training that specifically looks at serving immigrant populations? Because I would think that there would be a disconnect in some folks, both for legalities and for language issues.
Well, I would say that in the subject matter of our medical school, we clearly address that. We do probably more than most medical schools in teaching cultural competence. We basically teach Spanish in our medical school. But it's also important that we have a different attitude about who gets into medical school. This is something I learned in third world countries. It is not only the right thing to do to have doctors that come from the diverse populations that you serve, it actually makes more effective doctors. If all you want your doctor to do is prescribe medicine, we can and will teach medical Spanish. But if you want them to change the behavior of their patients, you know, to understand what they eat and exercising more and birth spacing and breastfeeding and a variety of other issues, having a physician that comes from the cultural background of his or her patients is very valuable. And so we put a value in recruiting students that come from our communities, are reflective of those communities, and they are, by the way, more likely to return to those communities and serve those populations. But they also have an extra skill set. They have the skill set of understanding the cultural and linguistic background of their patients in a way that would be difficult to teach. And so, yes, we put a high value on, if you will, on the diversity of our medical students, wanting them to be reflective of the populations they serve.
We have been working at KVCR with a specific hospital, talking about specific community needs of that hospital. That's San Gorgonio Memorial Hospital. As I'm sure you know, they're faced with a hugely growing senior population from Sun City and all the Del Boab communities. On the bench, they're talking, now that the economy seems to be coming back a little, 4,000 to 5,000 new housing, which will be, for young families, a lot of them affordable housing. They serve the Morongo casinos, native peoples, etc. Using them as an example, how do you think about your role, medical students, residents, etc., for that place, and how, as sort of a case study, might this work?
Well, let's just take a look at the medical environment we're talking about. And in this particular case, it's more than just the hospital. It is the existing doctors and clinics, federally qualified healthcare centers, doctors in private practice that exist in that particular environment. Now, any environment, particularly, let's say, a hard to recruit to environment, where would you begin? Well, the first thing to do is to recognize that if you had 2 equally qualified medical students, one from Barstow and one from San Francisco, you probably have no chance at all of ever getting the student from San Francisco to practice in that community. But if you can, in fact, recruit a student from Barstow and train them with a lot of contact with that community throughout their medical training, you have a fighting chance of that student ultimately ending up and practicing in Barstow. So the first thing you'd want to do is you'd want to strengthen the K through 12 programs in that environment. And that has not only the advantage of potentially training a few ultimate physicians, but also nurses, physician assistants. If you strengthen the STEM programs, also engineers, a variety of other good things for that population. But it's particularly important from a med school standpoint that you strengthen the K through 12. Because if you look at why students don't ultimately get into med school, some of the mistakes are actually made at junior high, such as selecting the wrong math track. Then you want to say, where are the students from this geographic area going to college? What community colleges, what four-year colleges? And you want to try to build success programs within those colleges that keep students interested in healthcare careers, but help them succeed with the science and other aspects of the curriculum that they need in order to get into med school. Then our medical school will give a selection advantage to students, and the greater the selection advantage is in a sense directly related to the need of that area. So even within inland Southern California, we would give extra, if you will, credit for coming from an area of inland Southern California in particular need over an area of inland Southern California, for instance, that has less of an issue. So we would give areas like that greater, if you will, admissions credit because we know the need is high.
So let's take the Banning Beaumont, let's take the Morongo tribe, and let's take the PhD program here in Native Studies that's unparalleled in the United States. In theory, then, all of this could work together with this new med school model.
It can, but since you brought up that model, let me say that I have explicitly looked at the problem of not enough Native American physicians. So let's look at that. Now, there are three backgrounds that are in very short supply of physicians that are, if you will, grossly underrepresented in their population. The African American physicians, there are probably only about a third the African American physicians we should have. Probably the greatest numerical shortage is obviously in Hispanic Latino physicians. They make up about half our catchment area and they represent only about 5% of the physician population. But we tend to not talk about the incredible shortage of Native American physicians. There are about 44,000 Native American physicians in our catchment area, and there's probably only 3 or 4 Native American physicians. So that number is really woefully small. And what's particularly woefully small is even the few Native American physicians in the state of California, many of them don't come from California tribes. So we obviously have a huge problem here because we don't even have very many positive role models that we can point to. So I would say, since I've been planning this med school, I've actually talked to the Native students at my own university, UCR, and there's a lot of bright students here, but they tend to differentiate into sociology, Native American studies, other fields. They tend to not be going into the hard sciences, and they tend to not be on a pathway to get into med school even coming out of their high schools. So in the short run, how would we address that? Well, that I would say is through a post-baccalaureate program. Let's take a really bright student that is, as you say, a PhD in Native American Studies that might want to be a physician and teach them the science component that they need in order to succeed in medical school through a post-baccalaureate program, and then we take them into med school. I would say that has the additional advantage of them bringing new skills to the medical profession. Skills that can be very helpful, such as anthropology and sociology and an understanding of their peoples that would be particularly valuable, in my opinion, in a healthcare professional. So that's a more immediate way to train more Native American physicians. And then, of course, recruit them into graduate medical education programs in our own area. So in that particular area, let's talk to the hospital about participating in graduate medical education to train family physicians, general surgeons, general internists, etc., so that we have the second half of the equation. And that also has both long-term and short-term benefits. In the short run, the faculty that we hire to run those programs deliver healthcare as well. So every faculty member I hire to serve as a teaching platform will also take care of 2,000 patients. In addition to that, the residents themselves deliver health care. And in fact, that's the only way I see for us to even begin to address the manpower needs of the Affordable Care Act is for me to go out and hire faculty now and start residency programs now so that they provide a short-term influx of new primary care doctors to deliver the Affordable Care Act. And then over time, we build this long pipeline to deliver more of our own students to our medical school, ultimately to our residency program. Now that'll take a long time, it'll take decades to do that, but ultimately that's the only long-term sustainable method of getting healthcare professionals to stay in areas like inland Southern California.
We haven't talked yet. We've kind of talked about lots of legs of the stool, but not about recruiting faculty.
Mm-hmm.
I would assume that with a kind of, I would call it radical model of
Mm-hmm.
medical school, that recruiting faculty is equally as challenging as proper students.
Well, I would say not as challenging as you might think. Certainly among primary care faculty, they're very excited about coming to a medical school that actually appreciates what they do. If you doubt that, ask your family physician, if you have one, how many times he or she was told in medical school that he or she was, quote, quote, too smart to go into family medicine. There's an incredible bias in many medical schools against students going into these fields that we need. So you can imagine that thinking about being a faculty member at a new medical school with a new focus, which focuses around what they actually do professionally, would be a very attractive model. And because this is a very unique model, I think we're probably the only med school in the country doing this, it allows us to actually recruit nationally. If you look at my leadership team, I have brought absolutely outstanding people here to this med school because we have an exciting new plan for medicine. And if you really want to make an impact in your life, you come to a place like this. I'll tell you a little story historically. Most medical schools taught medical education on the Flexner model from about 1908 into the 1980s and 1990s. In 1954, one medical school, Case Western Reserve University in Cleveland, Ohio, where I actually went to med school, introduced a radical new curriculum. It basically, instead of teaching pathology and physiology and biochemistry separately, they taught an integrated organ system-based curriculum, and they had early introduction of clinical practice the first day as a medical student. You were assigned a pregnant woman that you followed. You basically became a lay birth attendant, and then you eventually learned more. But you had early clinical involvement with patients from day one. It took 30 years, but basically every medical school in the United States eventually adopted some form of the Case Western Reserve integrated curriculum, which is now the dominant curriculum in the United States. If we're successful with this model, not only will we provide an outstanding source of physicians for inland Southern California, but if we're successful, every other med school eventually will adopt many of the ideas that we're promoting in this med school, and we'll be the model for a different type of medical education for this country. That's a very exciting thing for young faculty members. It's why they're coming to here. We've had actually no difficulty in recruiting outstanding faculty around what I think is a very exciting mission.
Loma Linda University
Mm-hmm.
is and has been in this area for ages. Are you partnering in any way? Are you taking advantage of anything they're doing? How is there any kind of relationship at all?
Well, first of all, let me just say that given the degree of physician shortage, the degree of the need, we are not competitive institutions. Neither is Western, by the way, osteopathic medical school. I need Western and Loma Linda to be successful, and they need me to be successful. The deficit is too great. And the fact that we have somewhat different focus is good. You know, Loma Linda is built around a more traditional university hospital, academic medical center basis, and I don't plan to build that model, so I'm glad it's there in our community. It provides important resources for our community that I wouldn't want to duplicate. I would say a good example of our working together is Loma Linda obviously runs our area's children's hospital. Now, I see absolutely no benefit in having more than one outstanding children's hospital in our geographic area, and I'm a strong supporter of that children's hospital. We need it in our area. It's not the area of business that I feel is what we should be doing, and we certainly don't need more than one. So I look at the whole area of pediatrics and say, what do we need? I think we need more primary care pediatricians. In fact, in the Coachella Valley, only because I know the statistics there, that is actually the specialty in shortest supply in the Palm Springs area. There's basically over a 60% deficit in primary care pediatric doctors. So we went to Loma Linda. And we need some aspects of a children's hospital to start a new residency program in pediatrics. Rather than us start a competitive program, we said, why don't we do this with you? So we're now in the process of rolling out a primary care ambulatory-based pediatric residency program as a subset of Loma Linda's Children's Hospital. It's actually under their residency training umbrella. We're going to run it with the focus that our medical school has, but we're actually strengthening the Children's Hospital, but we're creating a unique training platform that's consistent with our mission of training primary care pediatricians that stay in inland Southern California.
Let's talk about the other end, gerontology. More older people, living longer,
Sure.
doing it in inland Southern California. What's the gerontology model for UCR?
Well, what I'd like to do is what I actually created when I was in Wisconsin. The job I had before this job was I was the chairman of the Department of Medicine in Wisconsin at the Medical College of Wisconsin. And I always thought that of all the specialties, geriatrics is probably the absolute shortest supply, especially when you give the demographics of our aging population. And geriatrics is not a particularly popular specialty, and it is only 1 year long. Now, when you think about that, the training of geriatricians is one of the specialties that needs the most longitudinal learning, meaning you need the most learning over time, but if you will, the specialty of geriatrics is only 1 year long. So I started the first only integrated med-ger training program in the United States in Wisconsin, where I recruited students at the beginning of their graduate medical education training programs, and we basically taught them geriatrics through 4 years of internal medicine training. So I would like to see us develop integrated geriatric training in both family medicine and general internal medicine, because I think that you end up with a doctor that's better trained in geriatrics and is basically a doctor that's trained to take care of a geriatric population, not just serve as a specialist in that area. So I think you'll see that we will specialize, if you will, in broad areas that are more primary care oriented and less, if you will, procedure oriented. So for instance, in geriatrics, an integrated med-ger program or geriatric family medicine program. I think that, quote, specialities such as adolescent medicine, such as inflammatory bowel disease doctors that are not gastroenterologists, diabetologists that are not endocrinologists, focusing around certain chronic diseases of high prevalence in our area to give extra training for primary care doctors to expertly manage on the front lines those types of diseases is, if you will, the specialty orientation of our school.
So not to oversimplify it all, but needs-based would be the focus across discipline.
Because ultimately we are holding ourselves to a very high standard. I actually have to improve the health of the community I serve. That's the standard we're holding ourselves to. And if that's the case, then I have to say, where are the healthcare problems? Where are the greatest deficits? Where are the greatest healthcare issues? And I have to find a way of addressing it. Because if you will, it's a lot easier to go from the bottom, where we are in most healthcare statistics, to the middle than it is to go from the middle to the top. So I need to structure the school around the greatest needs of our population and find a solution to the problem. Other places say, well, what can we do? Nobody wants to go into primary care. Nobody wants to practice, in banning. I hear these problems, but we need to have solutions to the problems. Often they need to be a little outside the box. They may have to be different from whatever the people are doing, but ultimately we have to find solutions to these problems, not just whine about why they exist.
My final question is, in this, putting all this together, being here, what was your biggest surprise? What did you expect that didn't happen? What didn't happen? When you walked in here, what was the most surprising thing so far?
Well, I think the most surprising thing is the depth of the support of this community for this medical school. You know, I've been in 5 other medical schools in my professional career, and, you know, there's always a certain amount of town-gown tension that takes place. I've never been to a place that was more supportive than this community is supportive of this medical school. And I can tell you that they really proved it. Probably the low point in my professional career was I came out here actually thinking that the funding had already been arranged, by the way, and on June 28th of 2011, in the middle of our getting accredited, the governor dropped us out of the state of California budget. I don't believe there were more than 5 people that thought we could survive such a devastating event, and I think most people expected us to pack our bags and leave town. I went to our community, it's the only way I could think of doing it, and said, listen, I need your help to get this school open, even if we don't have new state support. This is not a wealthy community. You know, this is a hard place to raise money. In 9 months, we raised $100 million, $10 million a year for 10 years from basically this community. And based on that, we went back, got accredited, and we're now taking our first class in medical school. That is an amazing story. I wouldn't have believed it before I came here. It's hard to believe it now. The people of inland Southern California want and need this particular medical school so much they basically refuse to let it die. I think that's one of the greatest stories in American medicine.
Thank you very much.
That was good.
You like to buy?
Mm-hmm.